Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everyone, and welcome to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. Today, we are joined by the well-known veterinary orthopedic surgeon, Mark Glyde. Mark is an associate professor of small animal surgery at Murdoch University in Perth, Australia, where he leads Murdoch's busy orthopedic and neurosurgery referral service. He's a specialist diplomat of the European College of Vet Surgeons and holds a master's degree in veterinary surgery as well. Mark is well known internationally, having worked as a specialist in Europe and Australia and presented courses in orthopedics all over the world for over 20 years. Mark is also the chair of AOVET Asia Pacific and is on the AOVET International Board and the AOVET Education Commission. Today, Mark is going to present to us a conversation on the basics of elbow arthroscopy in the dog. So without further delay, I will turn the session over to Mark.
Thanks, Christopher, and thank you very much for the invitation. Thanks everyone for tuning in, and I really hope that you'll get quite a bit from this presentation that will help your elbow arthroscopy. When we teach elbow arthroscopy, I'm always excited to do this session because the elbow really is ground zero for arthroscopy. When you're looking to develop and refine your arthroscopic skills in canine surgery, the elbow is the place to start. So all of the skills that you pick up, hopefully in this session, are very much applicable to the rest of your practice. First of all, just to declare that I have no conflicts of interest that are relevant to this webinar. My university and Carl Stortz each year partner to present principles and advanced courses. I'm paid for that by my university. And as Christopher said, I'm not paid to present this webinar. In terms of what I would like you to get out of this session, I really want to reinforce your knowledge of topographic elbow anatomy. Whenever you're doing arthroscopy, confidence really starts with your understanding of the topographical anatomy. You've really got to have a mind's eye view of what you're about to put a scope into. This is really critical. So we'll look at that. We also, obviously, for confidence and to be effective, we need to really clearly understand the arthroscopic view of anatomy. So we'll go through that. We'll look at the key steps in successfully performing diagnostic elbow arthroscopy. So the entry, the egress, the scope placement, instrument portal placement. And it's critical that you are confident that you can do this every time. And hopefully by the end of this, you'll have achieved this. What we're not going to cover in this session is the surgical treatment of elbow disease. So this is all very much a principles talk to develop and refine your skills and develop your confidence. And then at the end, we'll summarize with really the 10 key points to make elbow arthroscopy very simple. So how we're going to do that, where are we going? We'll look very briefly at patient positioning and preparation and the operative setup. We'll have a look at the surgical instruments that we need to use, but we'll move on then to, in more detail, the topographical anatomy that I talked about. We'll focus on egress and scope and instrument portal placement, and we'll do that through looking really at two cases, one a disease case and one an almost normal case from the arthroscopic point of view. And then at the end, as I said, I'll summarize with 10 points to make life easy. So first with patient positioning. For elbows, the dog is placed in dorsal recumbency, and it's really uncommon to scope one elbow. I scoped a single elbow last week, and that would be the first single elbow I've done this year. Nearly always it's bilateral. So um, exactly how you clip and prep them's up to you. You can see our prep there. We drape in both elbows. With arthroscopy, of course, we need to use sterile, disposable, waterproof drapes. For the elbow, on both sides of the table, we need to have a firm fulcrum that we can abduct the elbow over. And having an assistant is really essential to getting a good outcome. It certainly saves you time, but it makes life a lot easier. What you can't see just in that bottom picture, just off screen, is that the assistant's hand is holding the sterilely wrapped foot, and you need to train the assistant in really three things. The first is that they pronate the foot. They internally rotate the foot. That's the first movement. The first movement is not elbow abduction. So first of all, pronate the foot, and this almost locks the elbow in position. And then they apply a gentle but steady abduction force across that elbow, just to open it up so that you can place the scope and the instruments. The third thing that they need to do is to monitor the egress, and we'll talk more about that. But you can do it by yourself, but it is much simpler and it's much faster if you have a trained assistant who's not going to vague out and lose concentration. So they're very much part of your skill set. In terms of where to position things, with arthroscopy, you need to think about ergonomics. You need to get the feng shui right. So have the monitor at eye level. Make sure that it is perpendicular to the surgeon, so that you don't need to swivel your head, you don't need to swivel your body. Just think of when you're sitting in your lounge at home and you're watching the television. You're not doing it with your head crimped to one side. So set it up right at the start. Have the instrument table close to hand between you and the monitor. This is a shoulder that you can see that's being done here. But if it's an elbow, we'd have the monitor in that edge of table position directly opposite the surgeon. And then when we move to do the second elbow, we'd change sides. The monitor would just swivel to the other side of the table. So again, everything is ergonomic. It's directly opposite where you are. Just one tip with the cables, you need to make sure that the cables are secure on the table, so that when the monitor is being moved position, that the cables aren't pulling instruments and bits and pieces across. When you set the table height, make sure that you set the height, same as any surgery really, so that your forearms are horizontal. You need to have as neutral a position as possible. And if I visit people who are doing arthroscopy, it always surprises me how, I think, challenging the setup they have is. They'll often have their head sort of kinked around, the tables at the wrong height. So make things easy. You need just to be focused on the joint. Okay, let's talk briefly about surgical instruments. So as with any arthroscopy, we need some syringes and needles. For a typical Labrador sized dog, I'd use 19 gauge needles for my Trailblazer needles, and I'll show you some video of how to do that. And then a sharp 11 scalpel blade each time. In terms of scopes, if you're starting out with arthroscopy, then the starting point is the 2.4. That's the most versatile for the typical size of animal that we'd be using. It's as you get more caseload, then having a a 1.9 scope for small dogs, so poodles and pugs and some staffies is useful. And then for the large and giant breed dogs, a 2.7 scope is very useful. But to start out, if you had to choose one scope, 2.4. In terms of diagnostics, the right angle probe, a graduated probe as pictured here that allows you to measure is absolutely essential. You need to have a probe to examine the joint. This is really critical. In the middle picture there, a switching stick. So switching sticks are just conical tipped probes that allow you to change out, if you need to, cannulas. You can switch scope position, and most commonly it lets you use an instrument cannula system, which is pictured at the bottom there. And so instrument cannulas, whether you operate through an instrument cannula, depends on the joint, it depends on preference. But for the elbow, when you're starting out, I think having an instrument cannula is very, very useful. And for most of the instruments we use, they'll fit down the large bore cannula. We also need to have a number of curettes, but if you're starting out, a 5.0 straight curette would be, again, the most versatile. In large dogs, you need a bigger boat, so bring a bigger curette. For the elbow, a banana knife is very, very useful. So just to cut away, loosen up the coronoid fragment with a banana knife, and then having a range of grasping forceps, rongeurs and punches are all very useful. And I think probably the one thing I would say with equipment is you get what you pay for. And I know a lot of colleagues will have bits and pieces that they've got online secondhand, and a little bit like doing DIY. If you want to make the job easy, have the right equipment. And this is where whichever company is in your area and has a good local rep with good contact, and they're prepared to come and visit you and really understand your needs and help you out, or particularly if they've got a veterinary division, this will make a huge difference. So I'd really encourage you to look at that. When you get into the operative part of treating the elbow diseases, then you're going to need some sort of either a hand mill or a shaver. I like to use a shaver in the elbow joint for coronoids, but this is something that, again, we'd encourage you to develop your diagnostic skills, become very good at triangulation, knowing exactly where your instruments are, exactly where the scope is, before you start using a power tool. So that's really essentially the basic equipment that I think you need for elbow arthroscopy. In terms of topographical anatomy, let's start looking at that, and we'll go through progressively and look at the anatomy specifically as it relates to where we're going to place egress and where we're going to place the scope and instrument portals, and we'll do that using video, looking at a couple of cases. So first of all, the critical thing is placing the egress needle. With arthroscopy, you have to have fluid in and fluid out. If you don't do that, then you can't effectively do diagnostic arthroscopy. So placing a egress needle is very easy in the elbow, and there's a number of ways to do this. And a bit like neutering an animal, you'll develop your own ways, but this method that I'm going to show you, we've refined over the years from teaching residents and teaching veterinarians in courses. So it's very reliable, it's very simple, and it's really aimed at trying to minimize complications. So I said at the start that it's absolutely critical that you have a good understanding of the topographic anatomy. This is going to give you confidence, and if you have confidence, then this is where the success comes from. So let's focus in on this a little bit more and just see what's in the area where we're operating. We always need to know where the bogies are. The great thing about coming in on the medial side of the elbow for arthroscopy is that there actually is very little in our way. It's a tight space, but we just need to be aware of what's around. Our landmark, our keystone, whatever you want to call it, is the medial epicondyle. So the first thing when you're about to start is palpate the medial epicondyle. Do this before you distend the joint with fluid. Depending on how diseased the joint is, it may be a little difficult to palpate the epicondyle once you've distended the joint. So first thing, palpate the medial epicondyle. If we look cranially, we know we've got the median artery and vein. These are, in arthroscopic terms, a mile away from where we're going to be, but it's important we understand this. We know we've got the medial superficial branch of the radial nerve right next to the cephalic vein, the cubital vein, and then proximally the brachial vessels and the median nerve. What is in our way, if you want to think of it like that, is the ulnar nerve. This is close to where we're going to be placing our egress needle. And when you're next doing arthroscopy, just palpate in this space where the ulnar nerve is. This is the concave space between the olecranon and the medial epicondyle, and you'll actually be able to blot or just move the ulnar nerve. You'll feel it moving there. And when we place the egress needle, the needle comes right past there, and it's almost impossible to skewer the needle. But maybe when you're starting out, to skewer the nerve. When you're starting out, just blot the nerve, feel where it is, and just go past it. But essentially, it's going to look after itself and move out of the way. We've also got this medial epicondylar ridge, the big rectangular corner of the medial side of the humerus, different to the lateral side, but it's a good landmark and important that we recognise it when we place our egress needle. We've got the flexor carpi radialis prominence. Again, that's palpable. In a diseased elbow, you're probably not going to feel it. And then we don't need to specifically know the flexor muscles of the elbow. And when we're doing arthroscopy, we can't palpate other than the pronator teres. So it's not like we're specifically choosing our scope portal to go between the muscles, but I think it's very important that you recognize the direction of the muscles, and when we're making incisions, to try and, if possible, cut longitudinally with the line of the muscles to minimize that damage. As you'll see, I'll show you in one of the cases, we can see these flexor tendons in that caudal medial compartment when we're doing arthroscopy. They're intra-articular, but they are extra-synovial. So we need to be aware of these. Okay, so how do we place the egress needle? And this is very, very simple. It's the same thing if we're doing a joint tap. We'd normally do that on the lateral side, but it's exactly the same principle. So again, we think of the topographical anatomy. We've talked about the ulnar nerve. And then if we have a mind's eye of the bony structure, and I think to be good at arthroscopy, you need really to have this mind's eye view of where you're placing your instruments when you do it. And a tip that I think, particularly when you're starting out, that can be useful is if you've got a true size lateral radiograph, then have it on your viewing box in the OR, and just refresh yourself with the size of the elbow, things like that. But you have to have this mind's eye view to be effective. When we place the needle, we're not trying to thread it in that tiny gap between the humerus and the trochlear notch. The joint capsule is distended in that area when it's diseased. We're really just trying to place it into that concave space. So it's very easy. It's not a difficult thing to do at all. So needle goes in, You usually feel it pop in, and then we draw out some synovial fluid. And this is a disease case. This dog has coronoid process disease. You can see that the synovial fluid was typically that slightly yellowy brown colour. It told us that the joint's diseased. Well, we already knew that. But don't forget that the amount of fluid that you're going to get out of a joint is really proportional to the severity of the disease. So getting out a small amount of fluid like that is really saying, well, this is relatively minor disease. In a very diseased joint with full thickness cartilage erosion, you could get from a Labrador sized dog 3 or 4 or 5 mils. So now we're distending the joint by injecting fluid. When you inject, if you're in the joint space, it's very easy to inject. There's no resistance to the plunger. And as you can see there, if you take the pressure off the plunger, you'll see that the fluid will you'll get bounced back on the syringe. So you need to distend the joint. Make sure that you're not injecting into the subcutaneous tissues. It's easy to inject and we get bounce back. And some people like to do this, to stand the joint and pull the needle out. I leave the needle in. I use it then for our egress until we place an instrument port. Okay, so we'll just take a break at this point. We're about a quarter of the way through, but if there's any questions, now's probably a good time just to catch up on those before we move on.
Yes, there are a couple, Mark. And again, I'd encourage people in the audience to please submit any questions on your mind. The first one is, you're speaking about ergonomics. Have you ever used multiple monitors? And do you think that would be helpful or a hindrance?
That's a really interesting question. I actually have to say I've never thought about it. I have not used I've not used multiple monitors. We have one stack for arthroscopy, one for laparoscopy, and we just slide it across. But I really don't have a useful comment. Christopher, do you have experience in that regard?
You know, I do. I more commonly see it with soft tissue surgeons when they need to move from one side to the other of the patient. It would certainly avoid your cable pulling issue if it were not inconvenient. I've seen it in multiple ORs, orthopedic as well, but more on the human side. I haven't seen it a lot in orthopedic surgery for veterinarians, but maybe it would be an advantage. I don't know.
Yeah,
Yeah.
interesting.
Someone has stated that they have been to plenty of CE talks where specialists talk about how common elbow disease is in dogs, but that doesn't seem to be our experience in general practice. Are there really that many elbow dysplasia dogs out there?
Yeah, that's a fantastic question, and thank you for the question. The answer is yeah, there are that many elbow dysplasia dogs out there. In immature dogs, under a year old, elbow disease is by far the most common cause of forelimb lameness, and it's very challenging for us to diagnose. And I think it's one of those things that once you recognize it, it's a bit like laryngeal paralysis. Once you recognize it, then you realize that walking into your clinic on a daily basis are a lot of dogs with elbow disease, elbow dysplasia. What makes it hard is that nearly always it's bilateral. And so these dogs have a symmetric lameness, and it's very hard to limp when you've got symmetric pain. You can't limp. All you can do is change your gait. And so we need to really key in our orthopedic exam skills and look for effusion. It's all about effusion. When we're looking at egress needle placement there on the medial side, if you flip over to the same spot on the lateral side, that concave space between the lateral epicondyle and the olecranon, if that is not concave, then almost certainly it's because of effusion. And if you push into that space, often you'll feel osteophyte. So it is common. You need to up your skills in orthopedic examination. We also need to recognise that plain radiographs are not completely reliable in diagnosing elbow dysplasia. So I suppose a long-winded answer to your question, but yes, it is common. Um, we as a profession need to get better at diagnosing it. And once you recognise how common it is, you'll be doing a lot of elbow arthroscopy.
Okay, one more question for now, which is when you inject into the joint initially, what volume do you inject? How do you know how much to inject? And do we assume that is saline?
No, that's right. And I'm sorry, I should have said it's sterile. It's sterile saline. It's the same fluid that we're going to run through the joint as we do the arthroscopy. So in terms of volume, you inject as much as is needed. So what does that mean? Typically, in an elbow, you'd put in about 10 mils. How do you know how much is needed? You saw when I was injecting that the plunger to press very easily initially, and then you'll feel the pressure build up. And if you put your finger on the joint, you'll feel the joint fully distended. So just go on the feel of pressure. Once you've got bounce back, then it's distended sufficiently. Great question. Thank you.
Okay, that's it for now, Mark.
Thanks, Christopher. And as Christopher said, I'd really encourage your questions. That's clearly if I'm not answering your questions, we want those questions. Great way to learn. So thank you for the questions. Right, so let's move on and look at how we now place the scope. And this is really the I suppose the critical step, because when I see people who are learning arthroscopy, the step they get stuck on is actually getting good vision, getting the scope in the right position to first of all get vision, and to get the right vision. A couple of millimeters can make quite a difference in an elbow joint. So this is again easy. I'll go through the steps. It's all about that topographical anatomy. Now, I've already said that our keystone point is the medial epicondyle. Everything comes back to the medial epicondyle. So everything is referent to that. Now, for placing the scope portal, we palpate the medial epicondyle, and essentially we take a line straight up the brachium, straight up the humerus. If we draw a line from the humerus down through the medial epicondyle, this is the line that we want to place the scope portal. In terms of where to place the scope portal, the position is about halfway between the medial epicondyle and that caudal surface of the leg. It's about halfway, and you can see there that ideally it goes between the muscles. It wouldn't always, but very commonly it'll slide into that space between the flexor muscles. So that's the starting point. Again, that mind's eye view is critical. You need to see the bone. You need to have a good idea of where the bone is, but that's the location for where we're wanting to put the scope portal. Now, a couple of other tips. We need to think about what I call 30-30 angulation. We'll come back a little later and look at some of that tendon and ligament anatomy, but for now, let's just focus on the scope portal. The 30-30 is that we need to recognize the exact shape of that trochlea of the humerus, the medial part of the condyle of the humerus. We know when we look at a craniocaudal radiograph that the trochlea slopes distally about 30 degrees. And so straight away that tells us that we need to tilt our cannula down about 30 degrees off perpendicular. The other 30 is that we need to recognize that the medial part of the coronoid process also slopes caudally about 30 degrees. So when you're placing the scope portal, we pick that spot. It's in line with the humerus running through the epicondyle. It's about halfway from the epicondyle to the caudal aspect of the limb. That's where we're going to start. But we tip distally 30 degrees, we tip caudally 30 degrees. So when it comes to the scope, think 30, 30 off perpendicular. We always use needles as trailblazers. My finger's on the epicondyle, and you can see I'm just carefully using that needle to trailblaze or to identify the point. Once we've used the needle as a trailblazer, we use that 11 scalpel blade and just to make an incision in the skin, and I'll play it again, but you could see that it just popped through the capsule. And I'd really encourage you to use the needle, use the blade carefully to just pop through the capsule. Why is that? Because it means when we place the scope cannula and obturator, we don't have to use as much force to penetrate the capsule. We don't want a big incision. Absolutely, we don't want a big incision. We think of making an incision that's about the size of the cannula. We don't want leaking around the scope cannula, but I don't want to have to force the cannula and obturator through a diseased joint. We know that when joints get diseased, very much they thicken up. And if we have to use a lot of force, if we have not made that small incision, then we have to use a lot of force, even if we use a finger stop so that we don't penetrate too far. Very commonly, we will do damage to the cartilage when we get through. So I'll just go again and show you. So here we are using the trailblazer needle. We're about halfway down. I'm just refining the 30-30. We're in, we can see fluid coming back. And now we use the blade just to make a stab. You'll see it just drop down there. So we know that we've made that little incision. And now without force, we can use the cannula to pop through. And again, we follow the needle line to place the scope. We always need to confirm that we're in. We're assured that we're inside the joint when we see that fluid come back out through the cannula. When you're connecting up your scope, instruct your assistant to not touch the cable, the light cable, before the scope is locked in. I've seen a case where the scope is just halfway into the cannula and a helpful assistant pulled on the cable, and that's when the scope's most at risk. When it's halfway into the cannula, if it bends, you've just broken the scope. So instruct your assistants that they do not touch the cables until the scope is locked into position, and make sure that you feel it click in. And once the scope's in there, it's very, very secure. The dangerous time is when it's being positioned into the cannula. And of course, the basic principles would say that you've instructed your assistants, you've instructed your technical staff never to hold a scope by the shaft. They always hold the scope by the base. If they hold a fine scope by the shaft when it's got a camera on it, they can easily bend it. There's enough bending force. Now, here's one of the critical tips. The biggest mistake that people make when they're starting out with arthroscopy is that they let the camera rotate round. The camera always points north. The camera doesn't rotate. And in the pictures there on the right, just think about sitting in your lounge chair and watching the television. The television's always horizontal. You don't have the screen rotated. When you take a photo, unless you're being really artsy, you don't tilt the camera. The camera is horizontal. And so for us to keep that horizontal position with the camera, we have the buttons pointing north. Now, exactly how you do this is up to you. I like to use a V grip. So I try and almost lock my wrist and keep a V-shaped grip. So it's very hard to rotate the camera. But if you watch people, that are learning arthroscopy, the most common mistake as they're trying to look around and trying to examine is that they'll rotate the camera around. And this really is self-defeating, because if the horizon is always changing, then you're going to struggle. And particularly when you come to do operative arthroscopy, if things are changing, it makes your triangulation of instruments very, very difficult. So one of the key tips, if you took nothing else out of this webinar other than keep the camera pointing north, then I'd be happy. That'll greatly simplify your arthroscopy. Now, the way we look around, again, I'll show you some cases. Yes, we do move the camera. We move the direction of the scope relatively a little bit. The way we look around is by using the light post. And what we need to recognize is that nearly all arthroscopes are not straight telescopes. They are angled 30 degrees. And so the angle is opposite the light post. And the best way to think about that is imagine that when you're looking, the light post is directly in the back of your neck. And so by moving the light post, you're moving your head around. That's exactly what you're doing. And by moving the light post 360 degrees, we can actually get this 360 degree view. So the arthroscope is not a 0 degree telescope. It's looking sideways at 30 degrees. If it didn't do that, we wouldn't be able to look around the joint. We're in a joint that's got a depth of about 3 millimeters. So this is essential for us to look around. It does cause some problems in terms of triangulating your instruments, and we'll talk about that. So here we are, we're in a joint, and we're just using the light post really to look around. You can see that we're moving the camera, and we are moving the position of the tip of the scope, but most of the looking around is in turning the light post. If you first get into a joint and you're not sure where you are, then the first step is to turn the light post. Look around. Think about a cat when it comes into your consult room. First thing it does is it looks around 360 to see what's there. Do exactly the same thing. So let's just have a look. Combined, here we are in the trochlear notch. We're looking up the trochlear notch. We're now using the light post to come down the trochlear notch. We've run the trochlear notch. There's the humerus above us. The medial part of the coronoid process is immediately in front of us. Out of focus, the radius is in the middle distance, and just using the scope to, we're changing the camera position. We're looking here cranial, and you can see we've got this large coronoid fragment that comprises about half of the medial part of the coronoid process. And that's a typical coronoid fragment. So the way we look around is by moving the light post, and we do it in concert with moving the camera. Whenever you're moving the arthroscope, you need to have what I call a horizon in sight. You need to have a definite line. Don't move the arthroscope around. Don't change position if you can't see anything. You need to have something, a line in vision to do that. Okay, let's look at how we place the instrument portal. We've placed the egress needle. The egress needle is critical for our vision. We need to have fluid coming out, otherwise we're not going to have vision. Second thing we do is we place the scope portal halfway between the medial epicondyle and the caudal aspect of the limb on the line along the humerus through the epicondyle. Think 30-30. We're tilted distally 30-30, we're tilted caudally 30-30. So now, where are we going to place the instrument portal? And this is, again, absolutely dependent on our topographical anatomy. So we've got our mind's eye picture of the bone. We're seeing the bone as we're looking at the skin. This is the position where we're going to place the instrument portal. So we're cranial. In a Labrador dog, we're about 10 millimeters cranial to the to the scope portal, and we're a little bit distal. We're on that curve of the humeral condyle. And again, we'd use the medial epicondyle as our reference line. So we come from the medial epicondyle and really take a line straight down the center of the antebrachium. So really between the radius and the ulna. And this is where we're placing it. Where we place the instrument portal, we're immediately caudal to the collateral ligament. So the collateral ligament there is marked with the upside down V, and our instrument portal goes in immediately caudal to that. Again, like we said with using a scalpel blade for the scope portal, think of the line of the anatomy there. We've got the pronator teres muscle. We don't want to cut transversely. We're going to cut longitudinally. And we want to cut longitudinally, obviously, with the collateral ligament. So we're in this space, we can't palpate that ligament, but when you put the scope in, you'll see the collateral ligament cranial to you. It's very obvious. Further medial, further outside the joint and distal to the collateral ligament, we've got the biceps tendon, and we won't specifically go into detail about that, but it's very medial. It's more difficult to see, but nearly always you'll see the collateral ligament. Now, exactly the same as the scope portal, we know that our instrument portal needs to be tilted distally 30 degrees because of this slope of the medial part of the coronoid process. So we've palpated the medial epicondyle. We're using our trailblazer needle just to get the line. And you can see that the light post is looking cranially. We're looking at where the needle's coming in. And in this case, the needle is a little bit caudal. So by just finding the ideal position for the needle, that informs me about the ideal line and position to place the scalpel blade. So let's go again. We're just from the epicondyle straight down the middle of the antebrachium. We're using the trailblazer needle, just palpating. I wasn't tilted 30 degrees distal enough. There we are. We can see the needle come in. It's a little bit caudal to our fragment. So I can see by angling the needle what the ideal line is. And now that tells me where I should make my incision with the scalpel blade. So we place it in on the same line. I like to see the scalpel blade go through, and again, we're being careful. We just make a longitudinal incision. There's some blood from the capsule. We see the tip of the blade come through, and I think of making, in most cases, about a 5 millimeter incision. We're just enlarging that capsular incision with scissors there. We want to have easy egress through this space. Remember that with a fragment that size, we're not going to get it out through a tiny incision. So in this case, we've made an incision that's probably 5 to 8 millimeters. At this point, the egress needle is probably redundant. Remember that fluid's going to come out through the lowest pressure point, but we need to make sure that we have easy egress. If we don't have good egress, then what's going to happen while you're concentrating on your arthroscopy is that fluid is going to go subcutaneously, and this is very dangerous. So you must maintain egress. Again, that's something that your assistant can help you with. So now we've got our instrument portal, and whether you operate through an instrument cannula system, I prefer to operate open. There are times when I use the instrument cannula, usually to flush the joint out. I can get higher volume egress, but now we can bring our instruments in. And at this point, if we were doing the operative side of things, we'd bring in a banana knife, we'd free up that fragment, and then depending on how much access we have, we could either grasp it and remove it in one, or very often we need to break it with a punch into 2 or 3 parts and bring it out piecemeal. Now, one of the things that people starting out with arthroscopy really struggle with is the angle of the operating instruments. If you look at the angle that this looks like, this is a 2 millimeter right angle probe coming in. It looks like it's almost at 90 degrees to the angle of the scope. And this is a optical illusion. Look at the position of the scope versus the position of the probe there. They're much closer together. And so this optical illusion is a function of that 30-degree offset of the scope. So it effectively adds 30 degrees to what we're seeing. It's not the true angle, but the problem is that when people are placing the instruments in, and it's much harder in a shoulder or a stifle joint where you've got a greater travel distance, the most common mistake is that people have too wide an angle. And what that does is that nearly always the instrument just passes straight behind the scope, and they really struggle to triangulate. If you are lost, if you put an instrument or a trailblazer needle in and you can't see it, nearly always you're at too wide an angle. Think about chopsticks. That's the tip I'd give you. Come back to a closer angle. Bring them so that they're less divergent. The angle that you use chopsticks at, that's the angle that you need for triangulation in an elbow. So don't get fooled by the optical illusion. Okay, we might just pause here for some questions. I don't know if we've had any more questions, Christopher.
I do have two questions here.
Fantastic.
First one is, what is the size or diameter of the instrumentation? Do they come in a variety of sizes, or can you use universal instruments for all cases?
Yeah, it's a really practical question. I actually don't know the diameter of those of the probe that I just showed you there. My guess would be it's about 2 millimeters. Instruments do come in a variety of sizes, but again, when you're starting out, talk to your rep and use if you like, the common size. So most of the instruments you're going to use are somewhere between 2 millimeters and 3.5 millimeters in diameter. If you're doing giant dogs, large breed dogs, then you're going to need bigger kit, but mostly between 2 and 3.5 millimeters. And Christopher, if you've got a comment, you know the diameters and of all your equipment, that's the range of most of the gear, isn't it, for dogs?
Absolutely. You've done it right there. Of course, it gets bigger for humans and horses, but for small animals, that's basically all we make. Yep.
Right.
And the other question is, I often have trouble with subcutaneous fluid building up and causing joint collapse. Do you have any tips to avoid this?
Yeah, definitely. That's a real practical question, a common problem for people starting out with arthroscopy. So it's all about egress. It's only about egress. And if you have not assured egress, if you do not have easy egress and you're pumping fluid in, particularly if you don't have a fluid pump, and I'll explain that a little bit more, but if you're pumping fluid in under pressure and you're concentrating on your arthroscopy and you or your assistant are not checking that there's egress, then the fluid is going to find its way out. And when it comes out, it'll come out of the hole that you've made in the capsule, and it will just diffuse into that subcutaneous tissue. The first thing you see, if you're actually noticing, is that you'll see swelling, subcutaneous swelling happening. And then the next thing, and it's really game over, and it happens very quickly, is that all of a sudden your vision, it looks like everything is compressed from the outside. It just collapses on you. And what's happened here is that the pressure of the subcutaneous fluid, it stretched the skin, it can't stretch anymore, and now it pushes the joint capsule down on you. And that's it, that's game over. Once you've got all this pressure in the subcutaneous tissue, you can't expand the joint capsule, you can't see anything. And that's it. So egress is really important. How do we make sure we've got that egress. So two things. We talked about having your assistant look at the egress needle, but when you make the scope portal, don't make a big incision. We don't want fluid coming out there. When you make your egress portal, when you make your instrument portal, bigger is better. You want easy access of instruments. You want easy exit of fluid. So that's the first thing I'd say. The second tip, and it costs money, but the second tip, and I'll show you an example or a picture of one later, get an arthroscopic pump. Once you have an arthroscopic pump, you won't get that problem. Life is easy. Arthroscopic pumps can be set for the joint size. They regulate the pressure and the volume that's coming in. Your nurses will love you, first of all, because you have much less fluid on the floor. So less fluid is coming out of the joint, but it controls the pressure. And if, when you're starting out, if you're using pressure bags or you're having staff squeeze the drip bag, then this really creates high pressure. It increases your risk of this problem. So they're the two main tips. Assure your egress, and ask Santa at Christmas time for an arthroscopic fluid pump. Once you've got one of those, you will never look back, and your nurses will love you. Great question.
That's it for now, Mark.
Okay, thanks again for the questions, and I'd really really encourage the questions. We'll have a little bit of time at the end, I think, for questions. All right, let's have a look at another case. This is a shepherd. This is a dog with immune-mediated joint disease, and so we'll just look at. It's not quite normal anatomy, but we'll use this dog to just revise the technique and look at some of the normal anatomy. You know the portals. We've looked at where we place the egress, where we place the scope, 30-30, where we place the instrument portal, where 30 degrees tilted distally, we're not tilted caudally 30 degrees on the instrument portal. There's the concavity. So we pop the needle in, nice and easy. You can see this is a pretty diseased joint. We've got this diffuse bloody fluid. It's inflammatory fluid. So this dog's got quite a significant amount of disease, and we can easily analyse that. That's all nice and simple. Bigger dog, so we've got a 20 ml syringe here. We don't want air bubbles. We distend the joint. We feel the joint distending. Here we've got redraw or bounce back. So we know we're in the joint. We're feeling the joint distending. And this dog's taken almost 20 mils of fluid. Bigger dog, 10 mils for a Labrador dog, big dog like this. So now we're palpating the epicondyle. We've taken our line up the humerus. We're halfway between the epicondyle and the caudal aspect of the leg, a little bit less than 10. We've used our trailblazer needle. We make a small stab. We just feel it pop through the capsule. Now, having seen the line with the needle, we use a finger stop, we pop the cannula in, we see fluid coming out. That assures us that we're in the joint, unquestionably in the joint. So we always want to see that fluid to make sure. If we don't have fluid, we're probably stuck in a thickened joint capsule. We click in. Now the scope is safe. We've told our assistants don't touch the cables till we're clicked in. We set our fluids in, we switch the pump on, fluid coming out. Now we've got vision. So let's go around and have a look at anatomy. So this is the radial incisure. We're now looking caudally, see the light post. We're looking caudally and distally, and we can see the radius pronating and supinating. That's the radial incisure. Proximally, we've got the lateral part of the humeral condyle, the capitulum. Over in the far distance, that little prominence is the lateral part of the coronoid process. Remember, it's one coronoid process. That's a 2 millimeter probe. We're pushing in on the left at the top, the humerus, the trochlear notch on the right, and that's joint capsule on the lateral side of the joint. We're looking through there. Now we run up the trochlear notch of the ulna. We're looking up to the tip of the anconyle process. beautiful, nice, smooth cartilage. There's our egress needle. We've got a little bubble, little air bubble there. See the way we're looking with the light post. We're looking up proximally, cordoproximally. There's our needle coming through. There's the joint capsule, the synovium of the joint capsule. This is where the joint capsule attaches and reflects. This is where we get osteophytes. Osteophytes can only grow where there's a blood supply. There's only a blood supply at the joint capsule. See how we're just moving the direction of the camera. We're looking very caudal. We've got the light post looking completely caudal. And this is a beautiful view of the flexor tendons. They're the fine vessels in the synovium that's covering the flexor tendons. There's flexor tendon running down there. Remember that the flexor tendons are intra-articular, extra-synovial. So beautiful, healthy flexor tendons, synovial reflection just cranial to that. This synovial reflection is exactly where you're going to see osteophytes when you look on a radiograph or when you palpate. Now we're looking distally, we're running down right into the distal part of the trochlear notch. There's a little bit of capsule. We're very superficial. Now we're looking at the saddle. That's where we'd see a IOHC, incomplete ossification lesion right between the lateral part of the humerus and the medial part of the humerus, or the trochlea. So let's try and summarize, and we'll see if we can bring that all together and look at these 10 tips for really easy, reliable arthroscopy, confident arthroscopy, because you need to be confident, you need to be relaxed. You don't want to go into these being stressed or unsure of what you're going to achieve. If you follow the rules that I've outlined, you'll have good success. So the first one is have good equipment. Unfortunately, vets pretty much around the world like to do things on the cheap. You can struggle, but the reality is if you want to do arthroscopy easily and do a good job for your patients, you actually need a bit of kit. Your world will be so much different if you have good kit. So find whoever supports you in your region for veterinary arthroscopy, make a relationship with them. We'd have our rep come out, it's probably every couple of months, just to have a look at how things are going, make sure that the equipment's all set up. So make sure you've got the kit. The way we charge for it, and I did the same when I had a practice, is that when you're using equipment like this, charge each client an amount. Charge them we call an arthroscopic usage fee. And so we know that arthroscopes are going to need to be replaced. We know that the punches and probes are going to need being replaced. So each client pays a small amount so that this goes forward, so that when it comes time to replace a scope, replace a cannula, get a new stack, then the money is there. I think that's really important. Think about the positioning and having a good assistant. The assistant needs not to vague out. They need to pronate that leg, and then they need to abduct it, and they can't be changing position. If they change the position of the elbow a lot, the skin moves, the soft tissue moves, and now your portals might not be quite where you need them, where you place them. So it needs a good assistant. Probably noticed in the videos that the assistant's one step ahead of me. They know what the next instrument is. That will save you so much time. It's really important. I can't emphasize enough how the confidence and your success is going to come from you knowing the topographical anatomy and having this really good mind's eye view of what you see in there. If you can't see it in your mind's eye, you can't do it. So you just have to really reinforce you. And maybe when you're starting out with elbows, having that true size radiograph just on your OR wall so you can have a bit of a look will help you. In terms of where we place the three needles, the three portals, this is it, the egress needle. Again, just be mindful of the ulnar nerve. The scope, where referent to the medial epicondyle in a line with the humerus, about halfway between the epicondyle and the caudal aspect of the bone. You can see it's not quite halfway, it's maybe 40–45%, but you'll get the idea. The instrument portal is in line with the epicondyle, and then take a line straight down between the radius and the ulna. It's cranial, a little distal to the scope portal, but rehearse these, try and practice. We need to know those points. Have your mind's eye very clear. If you don't have it, you won't get it. It's really critical. Same with the instrument portal. Just think about the anatomy that's there. We don't want to be too cranial. We don't want to be damaging the collateral ligament. Once you become good at this, you'll see the collateral ligament very clearly, and you'll know you're in the right spot. We've talked already about how important it is to establish and maintain egress. If you don't have fluid in and fluid out, it's like driving a car without the windscreen wipers on. You can't see anything. If things are muddy, you don't have egress. So do something to establish that egress. Make perhaps a bigger instrument portal than you think you need. That's the low volume exit for the fluid. You're not going to get fluid building up subcutaneously, as someone has experienced. And if you can manage it, get an arthroscopic pump. Your life will be revolutionized. Use a 11 blade to make a small stab incision in the capsule. The capsule is thickened, particularly when it's diseased. You'll feel the tip of the blade just pop through. And once you've made that small incision, then your entry with the cannula and obturator is so much easier. You're always looking for fluid to come out through the cannula. This assures that you're in the joint. If you don't have fluid coming out, then you're not in the joint, or you don't have enough fluid pressure. But before you place the scope in, make sure you've got fluid coming out. That assures that you're in the joint. This is the one tip that I said, if you've been asleep, wake up. This is the one tip I really want you to take, because the learning curve for arthroscopy is actually, it's challenging. If you're rotating the camera, you're exponentially delaying your learning curve. You're prolonging your learning curve. There can only be one north. There's only one horizon. Set it, maintain it. I use the V grip. Find some way so that your camera does not rotate. The way you look around the room 360 is by moving the light post. So you have to become good at this, moving the light post to look around. Pick the direction that makes sense for what you're looking at. In the second case, we saw that by using the light post, we could see all the very margins of the joint. So it's common sense, but it's often not intuitive. You need to know normal. In that second case, I showed you what was essentially a normal joint, although it was a diseased joint, but from the cartilage point of view, it was essentially normal. Practice is important. If you have ethical access to cadavers, then this is a great way to start. One thing I would say is, don't be too disturbed about small marks that you make in the cartilage. Obviously we want to avoid cartilage damage, but sometimes a trailblazer needle will make a small mark in the cartilage. Remember that things that are very close to the scope are going to look massive. Things that are far away are going to look smaller. So if you are doing a cadaver and you think you've done some damage, open the joint and look at it with your eyes, and you'll see that very often that damage is much less than you think. But again, we don't want to damage cartilage. And then the final tip would be, if you can manage it, get an arthroscopy pump. These are pressure and volume regulated. You can use it for different joints. It decreases the amount of fluid that you use, it decreases the mess on the floor, and it greatly decreases the likelihood of you having a complication. So this is a great place to spend your money. And then finally, and we might have time for questions after this, for those of you that are in Australia, we already said that we run an annual course or 2 courses in arthroscopy advanced and principles. We're very lucky to partner with Storts who do this around the world. We didn't run it last year because of COVID. We're hoping to run it later this year. The contact details are there, so hopefully COVID will let us run that course. There are other courses around the world. The various providers will run courses. So take a course and get some confidence that way. So I'll stop there.
Okay, Mark, I think we have time for a question or two. Firstly, I use. Do you ever get so much hemorrhage that the lavage cannot remove it and you can no longer see the joint? I use very cold saline for rhinoscopy when I get lots of bleeding. It helps. Do you ever do that with arthroscopy?
Let me just see. So, do I ever get so much hemorrhage? Is that the question, Christopher? Do I ever get so much?
Yeah, do you ever get so much hemorrhage that it obscures that you can't clear it with fluid flow?
Yeah, great question. And someone's obviously experienced that in a really diseased joint. A really diseased elbow joint, that can happen when you place the instrument portal. And that would be a situation where I'd place the switching stick in, put in an instrument cannula, and just for a time, increase the flow and increase the pressure on the pump, and then to continue working. In dogs with that don't have a coagulopathy, which is virtually all normal dogs, I find that's going to stop. So I've not had to do anything else. I don't use radio frequency in that situation. What strategies do you have, Christopher?
Well, like this person suggested, he normally uses cold saline. Mm-hmm. To be honest, in the joint, I don't have any particular strategies.
I haven't. I actually haven't thought of using cold saline. Our saline is actually warmed. I don't know whether cold saline would cause constriction. I can't comment, but I would look at just, as I said, increasing pressure, or I do look at increasing pressure volume using an instrument cannula, just to get that flow and accept there's going to be a bit more fluid on the floor, and usually after a couple of minutes it's resolved.
I think in a joint, my experience, like you, would be the pressure. I mean, I haven't seen the cold fluids help, but we don't have any choice in the nasal cavity. That you can't build up the pressure.
Yeah.
Okay, one final question, Mark. Why do you recommend the elbow as the place to start learning arthroscopy? Wouldn't the stifle being larger, or possibly even the shoulder, be easier places to start?
Yeah, really, really good question. Almost intuitive. When I started learning arthroscopy in the 90s, I was undirected. I had an arthroscope, and I was just trying to find my own way. So I thought, well, what's the biggest joint? I'll go for the stifle, and it nearly stopped my career as a arthroscopic surgeon. But why do I recommend the elbow? The elbow is a very shallow joint. It's very easy to get access. The anatomy is simple. Triangulation is very easy because we don't have depth. And so you can learn all of the skills that you need in the elbow joint. Also, as we said before, elbow disease is very common. If you start in something like the stifle joint, it is a big volume joint, but there's a lot of forest in the stifle joint, and you can very easily get lost in the fat pad, and it can dampen your enthusiasm for arthroscopy very quickly. We now have strategies where we can work around or over the fat pad, so we don't need to do a lot of shaving. We don't need to do a whole lot of radio frequency stuff. We've simplified it, but the depth and the complexity makes the stifle difficult. The same in a shoulder. The depth means triangulation is hard. So I think you need to, use your chopsticks at a shallow level initially. Get comfortable just knowing where your instruments are, and then go on to a deeper joint. That's what I'd say. Yeah.
Great. Mark, thank you very much for this extremely clear and helpful presentation. We appreciate your willingness to contribute to the Endoscopy Talks program. Once again, I'd like to thank all of you in the audience for joining us. In 2 weeks, we will learn about interventional uroendoscopy from Dr. Alex Gallagher at the University of Florida. Guaranteed to be an interesting talk. It will include interventions such as stent placement and the use of lasers in the urinary system.